This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, this is Stacey Clardy from the Salt Lake City VA and the University of Utah. Today on the Neurology podcast, we're joined by Elias Sotirchos from Johns Hopkins, where he specializes in neuroimmunology and particularly in central nervous system demyelinating diseases and the myelopathies. We're going to discuss his paper published in Neurology, Neuroimmunology, and Neuroinflammation titled Lupus Myelitis Revisited, a retrospective single-center study of myelitis associated with rheumatologic disease. Elias, thanks so much for coming on to talk about this topic.
Thank you so much for having me.
This is a paper that I was really excited to see the title of, so let's get right into it. I've never used this term, lupus myelitis, because the first time I heard it, I didn't know what to do with it, right? It just makes no sense to me, because lupus in and of itself, like how would it cause a myelitis? What would be the pathophysiology? So I've always thought using the term, at least for me, would be kind of dangerous, because if I put that in the chart, people would say, oh, we know the answer for this patient, right? And they would stop looking. So is that your experience? Is that why you did this? What did you find? Do I need to change my approach? Should I use this? What do you think?
I think that the results of our study really are in agreement with your approach. I think the main take-home message from our study is that we were able to identify an underlying etiology of the myelopathy in the majority of patients who had a rheumatologic disease and an inflammatory myelopathy. So what we found was that about half of the patients in this study had aquaporin 4 IgG seropositive neuromyelitis optica spectrum disorder, NMOSD. Now, this has been clearly described that NMOSD has a significant overlap with rheumatologic diseases, with a significant proportion of patients with NMO having either serologic evidence of rheumatologic disease or having a clinical diagnosis of a rheumatologic disease, such as lupus, Sjogren's, or others. So we identified half of the patients of having aquaporin 4 IgG seropositive neuromyelitis optica spectrum disorder, a condition that is known to have significant overlap with rheumatologic diseases, including lupus. And I think that this is a very important point of the article, because aquaporin 4 IgG has been proven to be pathogenic and to be associated specifically with a neuromyelitis optica phenotype. And so we consider it to be the underlying etiology of these patients. So it should be conceived as not as necessarily a manifestation of lupus, but as a coexisting autoimmune disease in people who have lupus or other rheumatologic diseases. I think another very important point is that in addition to aquaporin 4 IgG seropositive and neuromyelitis optica spectrum disorder, we were able to identify patients with other autoantibodies that have been more recently described and have become commercially available, especially MOG antibodies. And so I think that this is a very critical point, since commercial availability of MOG IgG only really in the United States became available in 2018. Prior to that, testing was largely limited in the research setting. And a lot of the studies on myelitis and people with rheumatologic disease that are older did not include assessment of this. And we were able to find about 7% of patients as having MOG antibody disease, accounting for an additional proportion of those patients. Furthermore, I think that a very important point is that of the patients who were seronegative for both of these autoantibodies, so what would be termed double seronegative myelitis by some, 3 of them fulfilled diagnostic criteria for aquaporin 4 IgG seronegative NMOSD, which has rather rigorous criteria. So these are patients who have a clinical and radiological phenotype consistent with the disease, but lack aquaporin 4 antibodies. Further supporting that while these patients don't have an identified autoantibody, they may have a disease that shares pathophysiology with aquaporin 4 IgG seropositive disease. And sometimes we've seen that patients who are seronegative but have a consistent clinical radiological phenotype are seronegative because they were tested at the wrong long time. We know that sometimes the antibody levels may fluctuate either naturally or in response to treatment, which is a very important point, as well as the fact that the sensitivity of the test for aquaporin 4 antibodies vary significantly. So older tests such as tissue immunofluorescence, which was used when the antibody was first discovered in the early 2000s, it has only about a 50% sensitivity, and the sensitivity of these tests has progressively increased over the years with the introduction initially of ELISA testing, and then especially with the introduction of cell-based assays, especially live cell-based assays, which have optimal sensitivity and specificity.
You make a lot of great points here. And, on the surface, you may be tempted to say, look, a lot of this is semantics, right? But to your point, the assays are getting better. And so now we're still cleaning up from some of these old, early, less sensitive assays, and we're able to refine the diagnosis. Well, some people had a one-time attack of myelitis 10 years ago, and now it may recur a decade later, and we're able to link those two attacks together and get them an answer. And more than an answer, this matters because what we're not saying is there's treatments that are now specific. It's a philosophy, if I'm hearing you right, like we should never be happy with a label without the pathophysiology, appreciating we're not going to get 100% of the diagnoses in this moment.
Yeah, I think that that's the critical point, that while you're right that somebody could say, well, this is semantics, they still have an inflammatory myelopathy, the characterization of that myelopathy and identifying a specific pathogenic autoantibody or an alternative diagnosis, such as multiple sclerosis, for example, has significant implications into how you're going to treat these diseases. Now, with the availability of FDA-approved therapies for neuromyelitis optica, with ongoing clinical trials in MOG antibody disease, with our huge armamentarium of treatments for multiple sclerosis. And then if we go down the list, like other conditions that we found, for example, Neurobichet's disease, which will often be treated with anti-tumor necrosis blockers. So there's a variety of treatments that can be tailored now to target the specific pathophysiology of the underlying disease. And that is really the most important aspect of why we need to be very thorough in our evaluation and identify an underlying specific etiology that accounts for the inflammatory myelopathy.
Absolutely. You even made me think of an example of one patient where I was having the darndest time applying a label because sometimes you can't do it on the first visit or the first attack. It was a patient who ultimately ended up being a neurosarcoidosis with a longitudinally extensive spinal cord lesion who had nothing to biopsy on a full body PET scan, right? No granulomas anywhere. Fast forward, the punchline was she developed some subsequently. We were able to go after them and prove that it was neurosarcoid. But in the meantime, I had a frank discussion and we opted to use a B-cell monoclonal therapy and it didn't work. And once we were able to secure the diagnosis, the TNF-alpha worked for that neurosarcoidosis. You're just reminding me of that case.
I completely agree. Sometimes time allows for things to declare themselves. That doesn't mean, though, that we can't treat empirically as you did in your case, because if there is very compelling evidence that this is a inflammatory myelopathy and that this is a relapsing condition, sometimes we will treat with some sort of a broad spectrum immunosuppressant in order to kind of cover our bases and make sure that we're covering all of the conditions, or at least many of the conditions that we're considering in our differential diagnosis. But you're absolutely right that we have to maintain a vigilance, especially in a patient where we have not identified this underlying cause, and reevaluate them based on new clinical manifestations, on new test availability, which is another point here. As I said, MOG antibody disease accounted for a not insignificant proportion of these patients. And this is an antibody and a disease that really only became available for testing and more defined as a distinct entity relatively recently as well.
If you had to take what you've learned from this, what you were doing previously in your practice, combine it all together, what testing approach do you think we should be taking in these undiagnosed myelitis patients with already a systemic autoimmunity flavor? How do you tailor your approach?
On the first hand, I think what's very important is to make sure to characterize the myelopathy correctly as to whether it is inflammatory or not by looking at the imaging features, the clinical features as well. Typically, an inflammatory myelitis will have a acute to subacute presentation. If it's hyperacute, you really have to think more about a vascular process. If it's chronic, while inflammatory processes can definitely cause chronic myelopathies, you often have to broaden your differential more to include genetic etiologies and other etiologies of myelopathy as well. But I think that the study clearly shows that the highest yield test in a patient who has a myelitis, especially, of course, a longitudinally extensive myelitis and evidence of a systemic rheumatologic disease, is going to be aquaporin 4 IgG testing. And this is a very important that even if it's negative, that you retest, especially if the initial testing is done by an ELISA, because I have a specific patient of mine, I remember, who had very clear evidence of lupus, was tested by ELISA for aquaporin 4 antibodies and was negative, and then was given the label of lupus myelitis. When they presented to my office for the first time and I tested by cell-based assay, they had a very high titer seropositivity for aquaporin 4 antibodies. So I think that based on our study, that accounted for half of the patients really would be the highest yield test. But then if that's negative, you really need to make sure that you're expanding. And that would be also based on what the clinical and imaging phenotype is. But MOG antibody testing certainly would be high yield in a patient with a longitudinally extensive myelitis, although sometimes patients with MOG antibodies can have short segment myelitis, or even quote unquote MRI negative myelitis, which I feel is more depends on the quality of the MRI rather than being truly MRI negative. But sometimes the changes can be subtle and difficult to detect. Although one has to be careful with MOG antibody seropositivity sometimes because its specificity is somewhat lower than for aquaporin 4 IgG, and low positives, especially, one has to be careful with to make sure that they're interpreted in the appropriate clinical and radiological phenotype as outlined in the 2023 International Consensus Diagnostic Criteria for MOG antibody disease. And one of the reasons I'm outlining that is actually one of the patients in our paper is a good example of this. So we had a patient who had a very clear neuromyelitis optica phenotype with a very high titer seropositivity for aquaporin 4 antibodies, but also had a very borderline MOG antibody seropositivity at 1 to 20, which is the cutoff for seropositivity by the assay that was used. And this was a patient with lupus, with very significant hypergammaglobulinemia, with an IgG level in the 2000s. And so we conceived of that as being relatively non-specific binding rather than being a true double seropositive case, which is a somewhat controversial topic in the field of neuromyelitis optica and MOGAD. Now, aside from those, I think that other important features to consider, and something that I didn't cover in my initial discussion, was that we actually excluded patients who had typical multiple sclerosis in a rheumatologic disease, since we really wanted to focus on quote-unquote lupus myelitis. But in our initial screen, we actually identified a relatively large number of patients who had coexisting typical multiple sclerosis with a rheumatologic disease. And again, just by virtue of MS being a relatively highly prevalent disease compared to the rare diseases that we're discussing right now, it does make sense that you will see patients who have multiple sclerosis and they should be treated as such. Notably, though, even though we excluded patients with typical multiple sclerosis who fulfilled the diagnostic criteria, when we focused on the group that kind of remained undiagnosed despite all of our investigations, a significant proportion of those patients had lesions that were short segment, eccentrically located, and presence of oligoclonal band. And while they lack typical lesions in other locations, we do know that sometimes people can have spinal predominant multiple sclerosis. And so we conceived a significant proportion of these patients who were unaccounted for by one of the etiologies that we were examining as having potentially disease within the spectrum of multiple sclerosis. And that would have important implications in terms of how to monitor those patients and how to treat them. Now, finally, I think there are rare potential etiologies that need to be considered, and this will depend on the clinical phenotype, including things like rare genetic autoinflammatory conditions that would need to be considered. Other things that could be considered would be things like lymphoma. We know that patients who have lupus or Sjogren's syndrome are at a significantly increased risk compared to the general population for non-Hodgkin's lymphoma, and we've seen patients like that who have had lymphoma involving the central nervous system being misdiagnosed with neuroinflammatory conditions. Whole body imaging, as was discussed previously, including CAT scan or whole body FDG PET scan, can be considered in patients with suspicion for sarcoidosis or malignancy with paraneoplastic myelopathy. And so if there are tract-specific changes, let's say, then you may need to expand your differential and autoantibody testing to include paraneoplastic antibodies that are associated with myelopathy. Other conditions that can be considered are things like anti-glial fibrillary acidic protein associated astrocytopathy, which may also be associated with a myelitis. And it's important to bear in mind that that is an antibody that is more sensitive and specific when tested in the cerebrospinal fluid rather than in the serum. So there are a whole host of considerations in order to make sure that you're not missing a treatable underlying diagnosis and able to provide treatment that is more targeted. But really, I think the take-home message is that testing for aquaporin 4 antibodies using a highly sensitive assay is going to be the highest yield approach in patients with rheumatologic disease and a longitudinally extensive myelitis.
I think your advice is well taken. Definitely start with the most sensitive assay for things like MOG and aquaporin 4 you can get your hands on. If things still aren't fitting, certainly reach out to a colleague. And I will say it's fresh in my mind, so I'll bring it up. When you were alluding to the genetic causes, we did have in the first week of November a 2-part series with Jennifer Orthman-Murphy and Justin Abatamarco talking about some of the genetic leukodystrophies and those that have spinal cord findings or not. As you mentioned earlier, some of these spinal cord seaming syndromes that don't have traditional lesions that are showing up. So there's so much in there, but I am really just so excited to hear you talking about keep looking. Don't throw an old-fashioned, for lack of a better term, label on things. Elias, this is really great work, focusing on how we can do better in the future and even now on our next follow-up visit for myelopathy patients, and the importance of using the right terminology, not just when talking to colleagues, but when talking to the patients so they understand that some of this is an ongoing diagnostic process and journey. Thank you so much for sharing your work with us today. Again, the title of the paper, and it's in N2, Neurology, Neuroimmunology, and Neuroinflammation, Lupus Myelitis Revisited, a retrospective single-center study of myelitis associated with rheumatologic disease. Thanks, Elias.
Thank you so much for having me.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.